In today's video, we'll discuss acute rheumatic fever. We will also discuss chronic rheumatic heart disease in continuation. This is a very easy topic to remember and is oftenly asked. So, what is actually acute rheumatic fever? So, it stands for it is an acute inflammatory disease which occurs as a sequel to infection caused by group A streptococci infection, right? So it is actually one thing more to stress here. It is a multi-organ or a multi-system disorder. It also involves the skin, the mucous membrane, the joints, the heart, and the nervous system, the subcutaneous tissue. Okay, now it is mostly seen in children or young adults. Okay, children and young adults. Now, coming on to the pathogenesis, as I mentioned before, it is a sequel of the infection of a group A streptococci. So, we know that group A streptococci is mainly known for causing infections of throat. So basically sore throat, right? So we have streptococcal pharyngitis. Okay, now suppose this is my group A streptococci, right? Now from here it will go on to a lot of things. First of all, there will be T cells. They will get activated by streptococci. Okay, now the B cells, they will produce anti-streptococcal antibodies. Okay, this is the streptococci and these are the antibodies. Okay, now all these will combine, right? And we will see that the antibodies and the T cells cross react. Antibodies and T cell cross react with antigens of cardiac, sarcolemma, and valvular glycopeptides. Now, after this, you will see that they will go into the heart. They will cause a lot of manifestations, one of them being inflammation. As I mentioned before, we will refer to it as pericarditis. Also, there is presence of Eschoff nodules in the myocardium. Now, in acute rheumatic fever, you get to say Ashraf nodules, but in infective endocarditis, you get to say oscillor nodules. Okay, then pericarditis, as I mentioned before. So, but recently we have come to know that acute rheumatic fever is seen to be caused by Coxsackie virus. Which is B4 strain, in which streptococci just acts like a agent, conditioning agent. So you can mention this for impressing the examiner. So recently Cox Sakai B4 is seen to be the causative agent and streptococci is seen to be an adjuvant conditioning agent, right? So now coming on to the clinical features. Now in clinical features, there's a very important criteria which is usually followed. So it is called the John's revised criteria. Over here we have some major criterias and we have some minor criterias. To remember the major criterias, I want you to remember the acronym SPEC. Okay, by SPEC, by S I mean subcutaneous nodules, by P I mean polyarthritis, by E I mean erythema marginatum, by C I mean chorea, by C I mean carditis. Okay, now for minor criteria, I want you to remember acronym. It is not a proper word, but you could remember it as FARP. Okay, like we have frappe, then remember FARP, right? So by F we have fever, by A we have arthralgia, by R we have raised ESR or positive CRP, by P we have prolonged PR interval on ECG. Okay. Also, you can mention about leukocytosis as a minor criteria. Now, coming on to the clinical features. As usual, we'll draw a diagram to remember more. So this is the person. Let's name him John because we want to remember the John's revised criteria, right? So first of all, we will see that there is Siddharam Korea. Now, it is also called as the Saint Vitus dance. In this, what happens is there are irregular movements while writing and things. Now, secondly, we can remember the subcutaneous nodules or the Aschoff nodules. Okay, then there is the joint polyarthritis, arthralgia. Now, a very important phrase is seen that a rheumatic heart disease, it licks the joint, it licks the joint and it bites the heart. Yes, it licks the joint and bites the heart. Okay. Now, as I mentioned before, sore throat will also be present. Now, the most important heart. In heart, what you get to see? First of all, in heart, you will see carditis. Now, the manifestations of carditis are dyspnea, palpitations, tachycardia. Okay. Then in heart, one more thing to remember, a keyword and the most commonly asked in vivas is Carles Combs murmur. Now what happens is we see that there is a soft murmur, there is a soft diastolic and a soft systolic murmur, okay, mid diastolic murmur. Now in subcutaneous nodules, these nodules will be painless and they will be felt over the bony prominences and tendons. They will mainly be seen on the extensor surfaces of the arms and legs of arms and legs. Okay. Then coming on to the skin manifestation, which was erythema marginatum, which we discussed widely in oral pathology. So basically, it starts as a red macule with a pale center, which later colsic. Now, these macules are seen on trunk and extremities. Also, there will be edema of the periphery because there is going to be heart failure. Now, an add-on which is not given in book, I think. So, other features. So this is to provide an edge. So remember the try to remember there's a person named Jack, okay, who has a maid and the maid milks the cow. Okay, and she is taking him from school. So she has a bag hung on her. The bag is quite darting. Suppose it's darting. I know it doesn't make sense, but remember, now the bag is darting and she has hung it on her shoulder like a disgusting pro. Okay. So I'll just write it so that you remember. Jack's milkmaid hung a darting bag like a disgusting pro. Now, what I want you to remember from this, first of all, we have Jack. So, by Jack, remember Jack in the box sign. This means that there is the constriction of lingual muscle. Constriction of lingual muscle. Then we have milkmaid. Milkmaid hand. Okay. Sign. Now, a milkmaid hand sign, it means that when you squeeze the examiner's hand or the finger, it relaxes as if you're milking a cow. Then coming on to third, hung was for, I remember, hung up reflexes. Now, this is due to myxedema, okay? Then coming on to darting. In darting, remember darting tongue. Now, bag of worms appearance. Now appearance is for this one is for lingual muscle constriction. Okay, this is for the constriction of lingual muscle and this one was for the one thing, it was for the tongue. Yeah, the tongue, it retracts involuntarily when it is asked to protrude. Okay. Then coming on to the next, after bag we have disgusting. By disgusting, remember dysarthria. Okay. By pro, remember the pronator sign. Okay. Pronator sign is basically when you hold the arm stretched, it gives a spooning effect. Okay. Now coming on to the investigations. In investigations, the foremost investigation that we do is blood examination. In blood examination, what you'll see is leukocytosis. You will see that ESR is increased and there is positive CRP. Okay. Then second is bacteriological and immunological test. Now in this, because it is a streptococcal infection, so we will do the blood culture and we will see that there are positive colonies of beta streptococci by the throat swab, and the ASO titer, it will be more than 200 units in adults and more than 300 units in children. Okay, now coming on to the chest x-ray. In chest x-ray, you will get to see cardiomegaly as well as pulmonary congestion. Then ECG. In ECG, there is going to be a prolonged PR interval. Also, first, second degree AV block, non-specific STT changes. On echocardiography, you will get to see cardiac echocardiography. You will get to see enlargement of heart and you will see valvular defects. Okay. Now coming on to the management, how do we treat it? So there are three aims of the treatment. First one is to limit the cardiac damage, to give symptomatic relief, to eliminate streptococcal infection. Okay. Now how will we eliminate it? We will eliminate it by antibiotics. Erythromycin 250 milligrams 6 hourly. Also we can give penicillin 500 milligram 2 times daily. We can also alternate it with injection, intramuscular injection of benzathine penicillin 1.2 million units. Okay, then bed rest. For symptomatic relief, we will give NSAIDs like aspirin. Aspirin in the dose of 60 milligram per kg per day. Now, aspirin has a number of side effects like tinnitus, also tachypnea, deafness, nausea, acidosis. Okay, we are going to give this till ESR decreases gradually. Now, we will also give corticosteroids like prednisolone in the dose of 1.2 milligram per kg per day if there is severe carditis. Okay. Then follow up is done so that we can prevent chronic rheumatic heart disease. Now what is chronic rheumatic heart disease? Chronic rheumatic heart disease is seen in patients who develop it during the first attack, or who develop carditis during the first attack or during recurrence. So it is basically seen in mostly 50% patients over a period of 10 to 20 years, so it is not much common. So now the walls are affected. First of all, the left sided walls are more affected, okay, than the right sided. Then you need to remember the sequence. So first of all, mitral valve, then aortic, then we have tricuspid, then we have pulmonary. Remember, there is mat p, there is a lip shade which is mat p, remember it like that. Now coming on to the pathology, how does really chronic rheumatic heart disease happen? Now first of all, there is an irreversible destruction. Whenever you see the word chronic, just sort of remember that it's going to be irreversible. Then to counteract, there will be fibrosis which will affect the walls and the adjacent structures. Now if there is fibrosis, it's going to affect the myocardium as well as the pericardium. Now it may further lead to heart failure, or it may lead to conduction disturbances. Now in walls, it will make the walls incompetent. Also it will cause regurgitation and it will cause calcification of walls. Okay. Now important thing, in calcification of walls, what you will see is you will see McCallum's plaque in left atria. Okay. um Then a very important thing to remember, there is a fish face deformity of the MS. Now the treatment. In treatment, we will treat carditis by, as I told before, prednisolone, mention the dose, and we'll give aspirin. Now if there are complications, so complications, may we will give a tertiary intervention, which is usually the last modality, which is surgery. So which surgery? Valvuloplasty. This completes rheumatic fever. I hope you understood. Thanks for watching.